Hello everyone, I am myself Dr. Rajesh Kubba. I am the general medicine educator. So in this session, we will be discussing the basics of the cerebellar disorders. So first of all, I'll give you a basic idea of the anatomy of the cerebellum, and subsequently I will be also discussing the respective cerebellar disorders. So if you take the cerebellum, it is the largest part. Right, this is the largest part which is present in the hindbrain. Right, it is the largest part of the hindbrain, and it is situated in the posterior cranial fossa behind the pons and cerebellum. This cerebellum, it is situated in the posterior cranial fossa behind the pons and as well as the medulla oblongata. So where is it present? It is present in the posterior cranial fossa. Okay, and it is present behind the pons and as well as medulla oblongata. And if you see whether it is an infratentorial or supratentorial structure, this cerebellum, it is an infratentorial structure. Right, this is an infratentorial structure. And what is the main function of the cerebellum? The main function of the cerebellum is it coordinates the voluntary movements of the body. Right, it coordinates the voluntary movements of the body. That is the main function of the cerebellum. And this cerebellum, it has the four pairs of nuclei. The nuclei which are present within the cerebellum include the nucleus dentatus, and the second important nucleus include nucleus globosus, and the third important nuclei include nucleus emboliformis, and the fourth important nuclei include nucleus fastigiae. Okay, so these are the four pairs of the nuclei which are present within the cerebellum. Now let me discuss about the anatomical division of the cerebellum. So if you take the anatomical division, right, that includes both morphological and functional division of the cerebellum, the phylogenetically the oldest part of the cerebellum, it is the archicerebellum. Right, archicerebellum, it is phylogenetically oldest part of the cerebellum. And what is this archicerebellum made up of? This archicerebellum, it is made up of flocculonodular lobe and lingula. Right, so flocculonodular lobe and as well as lingula, and it is chiefly vestibular in connection. Right, it is chiefly vestibular in connection. And what this archicerebellum do is, archicerebellum, which is chiefly vestibular in connection, controls the axial musculature and it also controls the bilateral movements. Okay, so it controls axial musculature and it also controls the bilateral movements. right? It also controls the bilateral movements, and these bilateral movements, they are used for locomotion and maintenance of the equilibrium. Right, used for locomotion and maintenance of equilibrium. So that is about the archicerebellum, right? It is phylogenetically the oldest part of the cerebellum. It is made up of the flocculonodular lobe and lingula, and it is chiefly vestibular in connection and controls the axial musculature and bilateral movements used for locomotion and maintenance of the equilibrium. Then the next important structure like what we have is the paleocerebellum. So this paleocerebellum, it is made up of the anterior lobe of the cerebellum, right? It is made up of the anterior lobe of the cerebellum, and the other parts which are present within the paleocerebellum include the pyramid and as well as the uvula of the inferior vermis. Okay, so these are the parts of the paleocerebellum, whereas the archicerebellum, it is made up of the flocculonodular lobe and as well as the lingula, whereas paleocerebellum, it is made up of the anterior lobe of the cerebellum, pyramid and the uvula of the inferior vermis. And this paleocerebellum, it is chiefly spinocerebellar in connection. Right, it is chiefly spinocerebellar in connection. Now, what is the function of the paleocerebellum? The function of the paleocerebellum includes it controls the tone, it controls the posture, and it controls the crude movements of the limb. Right, it controls the crude movements of the limb. Okay, so that is the function of the paleocerebellum, whereas the archicerebellum, the function was it controls the axial musculature and it controls the bilateral movements used for locomotion and maintenance of the equilibrium. Then after paleocerebellum, the next important structure what we have is the neocerebellum. Neocerebellum, neo, the word itself tells you phylogenetically it is the newest part of the cerebellum, right? And this neocerebellum, it is made up of the middle lobe, whereas paleocerebellum, it is or it constitutes the anterior lobe, whereas this is made up of the middle lobe, and it is chiefly corticocerebellar or it has chiefly corticocerebellar connections. Right, it has chiefly corticocerebellar connections. That means it is the one which connects the cortex and as well as the cerebellum, right? It has many connections connecting the cortex and as well as the cerebellum. And what is the primary function of the neocerebellum? It is primarily concerned with regulation of the pyramidal movements of the body, right? It is primarily concerned with regulation of pyramidal movements of the body. So pyramidal movements in the sense the fine movements. of the body. So that is about the neocerebellum. Now, so we have discussed about the archicerebellum, which is the phylogenetically oldest part, then paleocerebellum, and the newest part of the cerebellum is the neocerebellum. Now, before going ahead with the cerebellar disorders, let me discuss the functions of the cerebellum. What is the very important function of the cerebellum? That is the coordination. And it helps in carrying out the complex movements. And once the cerebellum is damaged, right, once the cerebellum is damaged, the individual will develop what is called dyssynergia. What is dyssynergia? It is difficulty in carrying out complex movements. Right, difficulty in carrying out complex movements is called as the dyssynergia. And here in patients with the cerebellar dysfunction, there is decomposition of the movement, right? So what is this decomposition of movement? So decomposition of the movement in the sense where the act is broken down into its component parts. Right, act is broken down into its component parts is called as the decomposition. So here there is difficulty in carrying out, what is dyssynergia? Difficulty in carrying out the complex movements, right? So the individual will have incoordination whenever there is cerebellar dysfunction. So the individual is unable to carry out any coordinated movements, and the same way they will have what is called dysmetria. Now what is dysmetria? Dysmetria is loss of ability to gauge the distance. So how do you test, right, loss of ability? To gauge the distance. So how do you test this? We will test by what is called the finger nose movement, wherein the patient or the individual has to touch the finger of the examiner and he has to touch his nose. So he has to do these movements repeatedly. Whereas in patients with cerebellar disorders, there is loss of ability to gauge the distance. The individual is not in a position to do the finger nose test. Okay, so there is loss of ability to gauge the distance, loss of ability to gauge the speed, loss of ability to gauge the power of movement. Okay, now if you see dysmetria, what happens is the individual will have what is called undershoot or overshoot. What is undershoot or overshoot? That is, the act may be stopped before the goal is reached, or the individual may overshoot the desired point. Okay, so here the act may be stopped right, the act may be stopped before the goal is reached. Right, the before the goal is reached, or the individual may overshoot. Right, or the individual may overshoot the desired point. That is what is called as dysmetria. So there is either undershoot, so the individual will touch the examiner finger and he is unable to reach his nose, or he will be able to reach his nose beyond the nose. That is called overshoot the desired point. That is called as the dysmetria. And the next important manifestation of cerebellar dysfunction will be dysdiadochokinesia. So, dysdiadochokinesia is loss of ability to perform alternating movements smoothly. Right? Loss of ability to perform alternating movements smoothly. Okay, so that is what is nothing but your dysdiadochokinesia. So what is this alternating movements, right? That is supination and pronation of your palm. So the individual will not be able to perform this alternating movements smoothly and rapidly. If the individual is able to perform this rapid supination and as well as pronation, that we term it as adiadochokinesia. And if the individual is unable to perform the alternating supination and pronation of the hands, that we call it as dysdiadochokinesia. Then followed by that, the another feature of the cerebellar dysfunction will be rebound phenomenon. So in case of the rebound phenomenon, the patient is asked to flex his elbow against the examiner's resistance. Right? Patient is asked to flex his elbow against the examiner's resistance. Okay. Now what the examiner will do is, the examiner will suddenly leave that particular resistance. The examiner then suddenly lets go of the patient's forearm. Right? The examiner then suddenly lets go of the patient's forearm. Now, in a normal individual, what will happen? And in individuals with cerebellar dysfunction, what will happen? Let me discuss. But the procedure is this. The patient is asked to flex his elbow against the examiner hand's resistance, and then examiner will suddenly go off the patient's forearm. That means he will remove that resistance. Now, in a normal individual, you will have what is called a check reflex. That means once the examiner removes the resistance, right, he will have a jerk, and then there will be stoppage of further movement of the forearm. But in case of cerebellar dysfunction, right, in case of cerebellar dysfunction, there is loss of the check reflex. Right, there is loss of the check reflex. Now, why there is loss of check reflex? Okay, I'll tell you. Now here what happens is, in a normal individual, whenever the resistance is removed, the flexor muscles, that is biceps, extensor muscles, that is triceps, both of them, they work in a coordinated manner, and thereby there will be a check reflex. That means there will be stoppage of the movement of the forearm, and it prevents the hitting of the face of the patient or the individual. So the check reflex is being maintained by the agonist and as well as the antagonist. Right, so the agonist and as well as the antagonist will maintain the check reflex. But In individuals, wherever there is cerebellar dysfunction, that coordination between flexors and extensors is lost, right? So whenever there is cerebellar dysfunction, the coordination right, the coordination is lost, right? So once the coordination is lost, because cerebellum is the one which will maintain the complex coordinated movements. So once there is cerebellar dysfunction, the coordination between the flexors and extensors is lost, and thereby patient lands up in striking the face. Right, ultimately the patient will land up in striking his face with his hand, and this is what is called as the loss of check reflex, right? So all this is mainly because of loss of check reflex. Right, so that is about the rebound phenomenon. So rebound phenomenon will be there. That means the individual will have loss of check reflex in patients in scenarios of cerebellar dysfunction. Next, and cerebellum plays a very important role in maintenance of the tone of the individual. Now, once there is cerebellar dysfunction, there is decrease in resistance to the passive movements. Right, there is decrease in resistance to the passive movements of the joint. So once there is decrease in resistance to the passive movements of the joint, what will happen is the individual will have what is called a pendular jerks or pendular knee jerk. I'll explain to you about this in detail. Right, they'll have what is called the pendular knee jerk, right, where the individual have the movements of the movements at the knee joint in the form of the pendulum. Okay, next, now in case of cerebellar dysfunction, there is also abnormalities of the gait. So the gait is ataxic gait, right? The gait is the ataxic gait, where the individual will have loss of balance while walking. That is called ataxia. So the gait is ataxic gait with a tendency to fall in the direction of the affected side. So the individual will have right, the individual will have tendency to fall in the direction of the affected side, and thereby the tandem walking, it is lost. Now let me show you about the tandem walking. So right, so this is your tandem walking, where the individual is asked to walk on a single line and he has to walk step by step, right? So after keeping the left step, and exactly in front of that the right step has to be placed. So in this way he has to walk, and that is what is called as the tandem walking. And this tandem walking is not possible, or it is being lost in case of the cerebellar dysfunction, right? And these patients, whenever they walk around the chair, right, on walking around the chair, what happens is the patient sways on the side of cerebellar lesion. right, the patient sways on the side of cerebellar lesion. That is what is called as the tandem walking is being lost. And why is that? Because of loss of coordination of the complex movements. So that is about the ataxia, or that is about the gait of these individuals. And followed by the discussion of the gait, you have to examine the eye in these individuals, or before that, let me discuss about the speech. Even if you take the speech, so the speech of the individual, it is through a complex coordinated movements. Right, it is through a complex coordinated movements. That is how the speech of the individual is. Like, first, the speech centers, they have to send the information to the laryngeal muscles, right, where the muscles will generate the voice, and the sound or the voice has to reach the mouth, and the tongue, it has to articulate depending upon what we want to talk. And this requires the coordination of the cerebellum. Now, once the cerebellum is damaged, then the speech disturbances will be there, and that we call it as the scanning speech, right, where there is this scanning speech is due to incoordination of the tongue. Right, incoordination of the tongue, okay, and that we call it as the scanning speech. And we also call it as the staccato speech. And why there will be staccato speech is, that is due to incoordination of the larynx. Right, that is due to incoordination of the larynx. Now, so if you observe here, there is difficulty in the movement of the tongue also, because the tongue which will maintain the articulation, the muscles of the tongue will maintain the articulation by the coordinated movements of the cerebellum. So in these individuals there is dysarthria. Right, in these individuals there is dysarthria, and this dysarthria is produced due to incoordination of the muscles of articulation. Right, due to incoordination of muscles of articulation. So difficulty in articulation of the speech, right, difficulty in articulation of the speech, that is what is called dysarthria. Okay, so the individual will have the speech disturbances in case of the cerebellar dysfunction. Scanning speech due to incoordination of the tongue, staccato speech due to incoordination of the larynx, dysarthria due to incoordination within the muscles of the tongue. And if you observe the pupil, right, these individuals, they have what is called jerky nystagmus. Right, they have what is called jerky nystagmus. Now, this jerky nystagmus, it is like you have a fast component and you have a slow component. The fast component of nystagmus, it is towards the affected site. Right, the fast component, it is towards the affected side. Okay, that means if right cerebellum is damaged, the fast component of the nystagmus will be towards the right side, and if left side is being affected, the fast component of the nystagmus will be towards the left side. So that is what is your jerky nystagmus. So there is a jerky nystagmus with the fast component of nystagmus towards the affected side. And I have said you that these individuals will have what is called the pendular knee jerk. So what do you understand by this word pendular knee jerk? At least 3 oscillations of equal excursion of the lower limbs from the neutral position is noted. So there should be at least there should be at least 3 oscillations, and these 3 oscillations should be of equal excursion. That should be of equal excursion of lower limb. Of lower limb, and this 3 equal excursion of the lower limb will be there from the neutral position. This will be there from the neutral position. Okay, so once you elicit the knee jerk, there will be equal excursion of the lower limb from the neutral position, and that will be minimum of 3 oscillations of equal excursion. Then these individuals will also have the intentional tremors. So what do you understand by the word intentional tremors is that when the individual is about to do certain action, during that time the individual will have tremors within the hand. That is called the intentional tremors. And this intentional tremors, it has a frequency of it has a frequency of 2 to 4 hertz. And this intentional tremors predominantly seen over they are predominantly seen over the limbs, the trunk, and as well as the head. These intentional tremors are predominantly seen over the limbs, trunk, and as well as head. And I said you intentional tremors means what? That is, the individual, whenever he is about to do any action, or this intentional tremors, they are precipitated or they are increased by emotional stress. They are increased by emotional stress, and they are attenuated by alcohol. And they are attenuated by alcohol. So that is about the intentional tremors. It has a frequency of 2 to 4 hertz, and it is predominantly seen over the limbs, trunks, and head, and it is enhanced by the emotional stress and attenuated by the alcohol. And the next important point is the titubation. So titubation is a rhythmic oscillation of the head on the trunk or the trunk itself. So there is rhythmic oscillation of the head. There is rhythmic oscillation of the head on the trunk or the trunk itself. Or the trunk itself. That is what is called as titubation, where there is rhythmic oscillation of the head on the trunk or the trunk itself. And if there is presence of titubation, it invariably indicates the disease of cerebellum. It invariably indicates the disease of the cerebellum or its connections. That is called as the titubation. Now, these are the clinical manifestations. that you will have due to cerebellar dysfunction. Now for suppose if there is any lesion, right, you have archicerebellum, paleocerebellum and as well as neocerebellum. For suppose if there is lesion of the vermis, which is the part of the cerebellum, what will be the clinical manifestations? Let me discuss that now. Whenever there is lesion of the vermis, this will produce the titubation, right, and these individuals will have truncal and gait ataxia. Right, the individual will have truncal and gait ataxia, where the individual is unable to sit and even unable to walk, where the individual will have loss of balance whenever the individual is walking or whenever the individual is sitting. And the individual will also have titubation, where there is rhythmic oscillation of the head over the trunk or the rhythmic oscillations of the trunk itself. Next, coming on to lesion of the flocculonodular lobe. So whenever there is lesion of the flocculonodular lobe, this produces predominantly the vestibular symptoms. Right, this produces predominantly the vestibular symptoms, and the symptoms of the vestibular balance include, right, what will be the vestibular symptoms? The individual will have the dizziness, or the individual will have feeling of off balance, that is loss of balance. And third important feature, feeling as if you are floating or as if the world is spinning. So the spinning movements, right, the world is spinning around you. And the other important vestibular symptoms include blurred vision. The individual will also have disorientation, then frequent falls. So these are the vestibular symptoms that the individual will come across whenever there is lesion of the flocculonodular lobe. Next, we have discussed about the neocerebellum, right? Neocerebellum is what? The newer form of or the newest part of the cerebellum. So whenever there is lesion of the neocerebellum, this will produce all signs of cerebellar lesion. Right, this will produce all signs of the cerebellar lesion. Now, all the signs of cerebellar lesions in the sense, they will have nystagmus, they will have titubation, right, they will have intentional tremors, they will have dysmetria, dyssynergia, dysdiadochokinesia, loss of tandem walking, pendular knee jerk. All these will be there whenever there is lesion in the neocerebellum. Now, if you take the lesions of the cerebellar hemisphere, same, the individual will have the development of ataxia of the limb or all the other cerebellar signs on the side of the hemispherical involvement will be there. Now, what are the etiologies, right? What are the etiologies causing the cerebellar lesion, the causes of cerebellar lesion? So, we have certain lesions which are acute in onset, right? And what are those lesions which have acute in onset of cerebellar lesion or cerebellar damage? That includes, number one, trauma, right? This will cause acute onset of the cerebellar damage, okay? Then infections, then followed by that encephalitis, fourth, cerebellar abscess, right? And few more etiologies causing acute in onset of cerebellar lesion is we have the vascular lesions. What are the vascular lesions which are acute in onset is, these vascular lesions include thrombosis of the posterior inferior cerebellar artery, that we call it as pica, right, posterior inferior cerebellar artery, or thrombosis of anterior inferior cerebellar artery, we call it as ICA, and even thrombosis of or hemorrhage from superior cerebellar artery, and lastly vertebro-basilar artery. Vertebro-basilar artery. So whenever there is thrombosis or hemorrhage of these vessels, the individual will develop the cerebellar signs and as well as symptoms. The individual will develop acute onset cerebellar signs and symptoms. Then we also have certain demyelinating lesions which will cause the cerebellar signs and symptoms, and these particular demyelinating lesions include multiple sclerosis, right, and this is also acute in onset. And next we have drugs causing the cerebellar damage, and these drugs include the phenytoin sodium. So phenytoin sodium, it is the drug which is used as an anti-epileptic, then followed by that barbiturates, and third we have the alcohol. So these are the drugs which will cause the cerebellar damage, and apart from that we have piperazine citrate, next we have antibiotics, aminoglycosides, that includes streptomycin, then followed by that gentamicin, and amikacin. Okay, so these are the drugs which will cause the cerebellar disorders. Now we also have certain endocrine disorder which will cause the acute onset cerebellar manifestations, and this endocrine disorder include hypothyroid state. Right, hypothyroid state. So this is the endocrine disorder which will cause acute onset of cerebellar manifestations. So whatever we have discussed until now, they are responsible for acute in onset of cerebellar symptoms, right? And what are all those disorders we have discussed? Number one, like we have discussed, trauma, infection, encephalitis and cerebellar abscess. Then we have discussed about the thrombosis or hemorrhage of certain vessels like posterior inferior cerebellar artery, anterior inferior cerebellar artery, superior cerebellar and vertebrocerebellar artery. Demyelinating disorders like multiple sclerosis, drugs like phenytoin sodium, barbiturates, alcohol. Then we have piperazine citrate and antibiotics like streptomycin, gentamicin and as well as kanamycin. Then endocrine disorders like hypothyroidism. Now, followed by that, you need to know the cerebellar disorders which will, the gradual onset of cerebellar symptoms. That means what are the etiologies which will cause gradual onset cerebellar manifestations? That includes congenital craniovertebral anomaly, right, congenital craniovertebral anomaly. So this will be the etiology which will cause gradual onset of cerebellar symptoms. And then we have neoplastic diseases. These neoplastic diseases include cerebellopontine angle tumors, that we call it as CP. CP stands for cerebellopontine angle tumors. Then we have cerebellar tumors. And third we have pontine tumors. Okay, so these are the neoplastic diseases which will cause gradual onset of cerebellar symptoms. CP angle tumors, cerebellar tumors, and then pontine tumors. And then what are the treatable cerebellar lesions? The treatable cerebellar lesions include the tumors, right? Cerebellar tumors. Then we have abscesses, then followed by that infection. Right, so these are the treatable cerebellar lesions. And not only that, the alcohol, once the individual stops the alcohol, the development of cerebellar symptoms will get reduced. Then hypothyroidism, treat the hypothyroidism, then cerebellar manifestations will be reduced. Then followed by that we have drugs, and these particular drugs include the phenytoin sodium. You stop the drugs, the cerebellar lesions will subside. And then the hemorrhage. So after having discussed about the drugs, which these are all treatable causes, and even certain vitamin deficiencies like vitamin E deficiency, vitamin B1 deficiency, and as well as it is your B12. Right, so B12 is your methylcobalamin. So when these vitamin deficiencies are being treated, then the individual will have the recovery of the cerebellar symptoms. Then we have Wilson's disease. So Wilson's disease is that where there is accumulation of copper in the body. So once this particular Wilson's disease is being treated by copper chelating agents, then the cerebellar symptoms can be reduced. Then neurocysticercosis. So if you take this neurocysticercosis, so where the individual has the infection with the tinea, the larval form of the tinea. So by giving albendazole, you can treat this neurocysticercosis, and thereby the lesions within the cerebellum will be corrected, and where the individual will have the recovery of the cerebellar symptoms. Then the other important infection is the Lyme disease. So Lyme disease, the organism is Borrelia right, the organism is the Borrelia burgdorferi. So this Borrelia burgdorferi, the one which is responsible for the development of Lyme disease, will cause the cerebellar lesions, and where there is development of the symptoms. And once you treat this Borrelia burgdorferi with adequate antibiotic like doxycycline, then the organism will be killed, and the cerebellar symptoms what the individual has developed will recover back. And then episodic ataxias can also be treated. So these are all, the treatable causes for the cerebellar lesion. So you should be able to make out what is the etiology causing cerebellar disorder, wherein if it is a treatable cause, we need to treat adequately, and wherein the individual will have recovery of the cerebellar manifestations. Now, if you take the basic anatomy, like we have what is called the brainstem, that is midbrain, pons and medulla oblongata, and this brainstem, it is connected to the cerebellum, and the connection between the brainstem and cerebellum is the cerebellar peduncles. So we have superior cerebellar peduncle, middle cerebellar peduncle, and then inferior cerebellar peduncle. Right, superior, middle and inferior cerebellar peduncles are there. So this cerebellar peduncles, they are connected to the cerebellum. That means if you take the superior cerebellum or superior cerebellar peduncle, superior cerebellar peduncle will connect the midbrain to the cerebellum, and middle cerebellar peduncle, it will connect the pons to the cerebellum. Then we have inferior cerebellar peduncle, where it will connect the medulla oblongata to the cerebellum. So that is about your cerebellar peduncles, superior, middle and as well as the inferior cerebellar peduncles. And this cerebellar peduncles will have the afferent tract, that is anterior spinocerebellar, and as well as the tectocerebellar tracts will be there in the superior cerebellar peduncle. And the efferent tracts, like what you have is the cerebello-rubral, then dentatothalamic, then dentato-olivary, and then festigio-reticular. So these are the efferent tracts. The middle cerebellar peduncle, if you see, you have the pontocerebellar and as well as the posterior spinocerebellar. These are the afferent tracts. And inferior cerebellar peduncle, if you take the afferent tracts, that includes the posterior spinocerebellar, cuneo-cerebellar, olivo, parvo, reticulo, and then vestibulo-cerebellar. And accordingly, you have the efferent tracts as well. So this is part of the neuroanatomy, but please remember, the brainstem and as well as cerebellum, they are connected by superior, middle and inferior cerebellar peduncles. So these will be the manifestations of the cerebellar lesions. But what are the cerebellar disorders? We have spinocerebellar ataxia, which is nothing but Friedreich's ataxia. Then we have the ataxia telangiectasia. So these two sessions I have discussed or I will discuss subsequently, right? You can see a separate section on Friedreich's ataxia, that is spinocerebellar ataxia, and you can see a separate section on the ataxia telangiectasia. So this will be the basic introductory part of the cerebellar disorders, wherein we have discussed the basic anatomy of the cerebellum, then the functional and morphological divisions of the cerebellum. Then we have also discussed what will be the clinical manifestations if that particular part of the cerebellum is damaged. Then overall what will be the cerebellar manifestations, and lastly I have taught you like what are the etiologies which will cause the cerebellar disorders. So with this we will wind up this session on the basic introductory part of the cerebellar disorders. Thank you very much.